Thank you for joining us for another episode of the We're All Patients podcast. Today, my guest is someone who lives and breathes rural health. Dr. Matt McCullough is the Rural Hospital Improvement Director for the Utah Hospital Association, where he works closely with all 21 of Utah's rural hospitals to support improvement initiatives and long-term sustainability. He's also the Executive Director of the Utah Rural Independent Hospital Network, also known as the Rural 9, a coalition of 9 independent hospitals working together to tackle shared challenges. Before this, Matt was a key voice in the world of telehealth. He led the Utah Telehealth Network and served as principal investigator for the Northwest Regional Telehealth Resource Center, helping providers and patients across 7 Western states make care more accessible. He's also a former director of the Utah State Office of Rural Health and currently serves as the president-elect of Rural Health Association of Utah. And yes, he's got the academic chops too, earning his doctorate in health geography from the University of Utah. Dr. Matt McCullough, welcome to the show.
Thanks, Sam. Happy to join the show and be able to talk about rural health with you today.
Right on. Okay, well, so yeah, let's just jump into it here. And I was curious, what do you love about what you do?
That's great question. There's a lot of things I love about what I do. I would say primarily it's the people that I get to work with. People who work in rural health are passionate about what they do. They don't give up. They realize that it's critical to their community, and they live in the community, so it's part of their community. They're providing care to their neighbors, family members, and they're just good people who care about providing the best care possible to their community. And so I love getting to know them. Just kind of a funny antidote here. I tell people all the time, you don't know a rural hospital until you know the best things on the menu in the cafeteria. And so I love doing site visits, visiting the hospitals, eating in the cafeteria, really getting to know what the hospital has to offer their community.
So it sounds like you really like the people who you're helping and the people you work with. And it seems like that ties in directly into your, I mean, it's front and center, even on your LinkedIn page, the fact that you're on a mission to make geography irrelevant in health. What does that end goal look like to you?
I mean, really, it's so that people living in a rural community have the same access and quality to healthcare that anyone would have living in an urban community. And it came from a quote. You've probably heard this quote before. It's attributed to Jack Lord, who is an MD. But the quote was, "Geography is destiny in medicine." And I heard that quote when I was starting my PhD program at the University of Utah. And from a research perspective, I always kind of approached it as, oh, well, that's interesting. Let's research that. Let's figure out why, but it's too bad. It's too bad that if you're in a rural community, you're destined to, worse access and worse quality of care. And as I had different jobs in rural health and telehealth and at the hospital association, it kind of dawned on me one day that it doesn't have to be that way. And so I kind of made it my mission, and I flipped that script and said, my mission is to make geography irrelevant in healthcare and to do all that I can to help bring access to specialty care, improve quality. And I can talk about some of the things I'm trying to do and projects we're involved in to improve operations and finances, so that our rural healthcare system is healthy and functioning as well as an urban system.
I find that fascinating actually, because it seems like these days, especially, everyone's talking about how they can cut services, how they can cut costs, um, being able to survive in today's environment, and so on. I think you're really the only person, or one of the only people I've heard talk about actually not just cutting services, not just holding services steady, but actually increasing the things you offer to the community. And as you mentioned, focusing on quality and things like that. Usually, quality is tied to, oh, that sounds expensive. So, how did you get past that thinking, or how do you I guess, how do you make quality not sound more expensive and actually make that a goal?
Yeah, that's a great question. And I think there's kind of two parts to that question, right? Is how do we improve quality, but also expand services to the community? Um, Rural health is all about community and understanding what services the community needs, and trying to figure out how to offer those services. If a community needs cardiology, it's not easy to recruit a cardiologist to work in a critical access hospital and keep them busy, right? So you're not going to be able to recruit one and keep them busy full time. So you've got to think outside the box. And to me, that typically means partnerships. You don't need to join a large healthcare system. You don't need to be acquired, but you could find a cardiologist who's willing to come down once or twice a month to your rural community and fill their day full of patients who need to see a cardiologist. You can also bring them in through telehealth. So often, I think hospitals and in rural health, we limit ourselves to thinking, oh, well, we don't have enough volume for that specialty in our community, so we can't have it. And with technology, I just don't think that's the right answer anymore. I think it opens the door to, bringing them in through telehealth, and expanding service lines. And the truth is, those specialty service lines bring in revenue. And so, it's kind of one of those difficult things, but you've got to try. You've got to expand those service lines that then bring in additional revenue and benefit the community. And that's a challenge to do, but it is possible. But again, I think a lot of it comes back to partnerships and finding those systems or the academic medical centers who are usually more than willing to find a way to make it work and collaborate, send specialists to your community, um, so that you can provide that high quality care. So the second part of the question about the cost of quality, um, in my experience, what I really see is that increased quality comes down to um, better operations, right? So let's talk about just nursing for a minute. Um, if you've heard of the IPASS system for nurse communication, it's really a system about improving your operations and better communications, which then turns into better patient experience and patient care and improves overall quality. IPASS is one example, but it's not that expensive to implement a new way of operating compared to a whole new quality system. So again, it's kind of thinking outside the box. Um, and rural is great at innovation, right? I mean, you have to always try to do more with less, but I think you can improve quality by pretty simple, inexpensive operational improvements over time.
Out of curiosity, so as you increase quality, have you noticed that it impacts your costs in a positive way at all, in terms of increasing quality helps lower your costs?
That's a great question as well, especially as we start to try to transition to value-based care. That's the goal, is that increased quality will also help increase revenue, decrease cost. I've spent years trying to figure out, how do we make value-based payment work in a small critical access hospital with low volume. And there's not a real clear answer, to be honest. It's not easy. Um, Not easy for a small rural hospital with low volume to be part of an ACO and find shared savings. So I think that's the goal. Figuring out exactly how to make that work in rural health is the biggest challenge right now.
And you've mentioned too that actually my past conversation with you that sometimes the gap in care in urban setting could be as bad or even worse than in some of the rural areas that you've seen. How does that happen?
Yeah, for years I've heard people use the saying that rural is older, sicker, and poorer. And I never liked that saying. Um, Data may show that in some ways, but I have family that live in rural communities and they love it. Most people stay in rural because they love the lifestyle, and they have better air quality, probably more access to recreation, right? I mean, the nature and state parks and national parks are right at their back door. So there's a lot of great things about living in a rural community. Um, that comment that I made about access being worse often in urban communities, that comes from when I worked for the Utah State Office of, I ran the Office of Rural Health, the SOAR, State Office of Rural Health. And we did a primary care needs assessment every few years, using data from the state health department. And let me just, I pulled up some of these data points that I've been thinking about for years because I thought they were so interesting. So kind of my point here is that um, access to care is not always defined by geography. I think we often think that if you're in a rural community, you have worse access to care. And I don't think that that's true. It may be harder to access specialty care, but in terms of primary care and emergency care, let me share some of these data points. So this is Utah specific, right? This isn't national. Percentage of people who don't have insurance, top three highest are in an urban area, and 7 out of the top 10 are in an urban area. Unable to get care due to cost, 8 out of the top 10 are in an urban area. No personal doctor or primary care provider. All top 3 are in the Salt Lake Valley. And no routine medical checkup in the last 12 months. Kind of the same thing. 7 out of the top 10 are urban. And the highest with no routine medical checkup in the last 12 months is right in the Salt Lake Valley. It's not in rural, it's not in a frontier area. And that always surprised me so much, because I think I thought the same way, that rural areas had worse access to care. But what that data tells me, and I've been thinking about it for years, is that access to care isn't geography. It's, do you have insurance? Do you have a primary care provider? Are you having a routine medical checkup? And you can do all those things in a rural area. You can have good access in a rural area. But like I said, that it may be harder to access specialty care, but that's what we're trying to solve through telehealth and partnerships with systems.
So it sounds like when it comes to uh, bringing telehealth and services like oncology, cardiology, and others to rural areas. It seems like you have like um, a success story that you're especially proud of when it comes to that, like a specialty that you were able to bring in that that really helped the community and perhaps maybe even could be repeatable in other counties or states.
Yeah, for sure. There's actually a lot. I think today I'll focus on our tele-oncology program. But let me just mention, I think one reason this is working so well in general is again back to partnerships. We have these incredible partners to work with in the state. Um, we have almost a dozen telehealth services that are offered to our critical access rural hospitals through Intermountain Health, which is the largest healthcare system in Utah, and the University of Utah, who is our academic medical center. The university offers, and they've been doing telestroke and teleburn for decades. They have an incredible telestroke program, some of the fastest response times anywhere in the country. Intermountain Health offers teleoncology, telecrisis, critical care, neonatology and ICU, telehospitalist, infectious disease. There's a long list of them, but as I read those and you think, man, to have access to those specialty care services in a critical access hospital in a small rural community in Utah, um, we have a critical access hospital in a small town of 2,500 people. It's 5 hours from Salt Lake City. But to have neonatology ICU support right in that hospital is an incredible benefit.
It's amazing. Wow.
Yeah, so it's the support and partnerships, right? The systems aren't trying to buy up our independent hospitals, but they want to support them, and providing these telehealth services is how they're doing that. So we have 9 independent rural hospitals in Utah. They're part of our Rural 9 network that you mentioned. And a number of them have agreements with Intermountain Health, who's providing tele-oncology. So the way that works is the hospitals are actually able to keep their patients local. They don't have to travel 3 hours into Salt Lake for chemotherapy. They do all the chemotherapy and infusion therapy right there at the hospital. And all the visits with the oncologist are done over telehealth. So patients absolutely love the program. They can stay in their community. I mean, you've heard stories like this before, but there have been patients in these communities who simply decided not to do treatment because of the burden it would have been on them and their family to travel into the city and back multiple times a week. So that's it's heartbreaking, but I think we're changing the status quo by utilizing telehealth, bringing oncology services into these rural communities. The largest program we have right now is seeing over 60 cancer patients per month in their community, and they're just doing an incredible job. The 340B discount program for rural hospitals really is a lifesaver here. Cancer chemotherapy drugs aren't cheap, and the 340B program allows the hospitals to purchase those drugs at discount prices, and really just makes that whole program possible in these rural communities. So I'd love to tell that story. We've got at least three or four of our independent rural hospitals now doing tele-oncology, and it's something I'm just really proud of.
Wow. So, I mean, obviously they wouldn't be able to provide that kind of thing without the technology of telehealth in terms of like there's not enough volume there to attract the oncologist or to even maybe even pay one full time otherwise.
Right. Yeah, I think it really has to be a partnership with a system or academic medical center that has the providers and the program in place to be able to expand it to a rural community, kind of that hub and spoke model.
And it seems like this isn't just unique to Utah. Like other states can do similar things with their where the big hospital systems can help support the smaller, like rural hospitals, the critical access and hospitals with these kind of resources.
Yeah, absolutely, they can, and it is happening in other states. It's independent hospitals are being swallowed up, I guess. And sometimes it's good if it's better than them not being able to keep their doors open. It's better than losing all those services in a community. But there's also great benefits to staying independent and having an independent hospital in your community that is governed by a board of directors who live in the community, who care about the community. I often think about both Amazon and Walmart, recently in the last few years got into healthcare, and they've now both closed all their clinics.
Right.
And their reasoning was rural health is not affordable. Like they couldn't figure out how to make the finances work for it to be profitable. So, I go to my rural hospitals and I say, if Amazon and Walmart can't do it, how do you do it? How are you making it work? And they can list all the challenges they have, but what they have, to be honest, that I don't think Amazon and Walmart had was the people who live in the community, who honestly care about keeping their doors open no matter what, who will work longer shifts, who will work over weekends and holidays, who realize that it's their neighbor or their in-laws who are the ones coming into their hospital depending on them. And I just think that's something that's incredibly valuable that maybe larger corporations are missing, that magic, that piece of what makes rural health what it is.
Sounds like it's almost like mission driven in terms of when Amazon or Walmart is doing it, the people who work there at their clinics might not really feel the same kind of connection to the community, same kind of mission that the people who uh, work at these clinics and the hospitals in rural communities and live there too, uh, the kind of the connection that they feel to these places.
Yeah, I think they were too profit driven. And one example of that, if you look at the data this year, they're saying that over half of the rural hospitals are operating in the red. So if you're, a clinic or a hospital operating in the red in a for-profit corporation, what's going to happen? There's no way they're going to keep the doors open, right? They're losing money. But a lot of these rural independent hospitals are government owned, right? They're county hospitals. We even have a couple city owned hospitals in Utah. And I think that changes the dynamics when it's county owned, even if it's independent, not for profit. Like I said, the board of trustees are farmers, they're ranchers, they're local business owners, and they are going to fight tooth and nail to keep their hospital open in their community. I think we often also look at the challenges with maternal care. A lot of rural hospitals are closing, labor and delivery departments. And I'm pretty much told by most of our rural hospitals that labor and delivery continuously operates in the red, right? It's not making money for the hospital, and so they're supplementing the labor and delivery department with revenue from other departments. But they do that because they realize their community absolutely needs labor and delivery. They don't want mothers traveling, an hour or 2 hours to another community to have to deliver their baby. So it's just really the spirit of rural health, I think.
Well, yeah, and it seems like with the like maternal and fetal health too, it's um, if you cut if you cut services like that, then it also has kind of like a follow-on effect of then that community might not attract uh, people who might have otherwise either lived there or moved there to stay uh, in that community, because if there's not, if it's a young family, for instance, they might not want to stay there if there's no maternal care or fetal care, and they can't um, like essentially it feels like if some services like that are cut, then it also might cause like a little bit of an exodus of people who might live or want to live in that community to actually move somewhere else.
Yeah, I think that's possible. The other thing that I do hear is, hospitals that either close labor and delivery or convert to rural emergency hospital status. So they still stay open. They're there for emergency medicine, but they tell people for labor and delivery, you've got to go to another community. Well, if you're going into labor, you're going to go to the closest emergency room. And so people still show up at these rural emergency hospitals and expect to be able to receive help to deliver their baby, even though there's no labor and delivery department there. So then you're risking quality outcomes, right? There's a lot that goes along with it, but I think definitely people could start leaving the community if they don't feel like the services that they need for their healthcare are available.
And if they do that, then kind of also could cause the hospital perhaps especially over the long term, to have less revenue and less uh, patients and so on. So I like what you're doing with increasing services, because um, it's because when I feel like when people are looking at where to live or where they move to, um, healthcare, where easy access to hospitals or healthcare may be a criteria where um, maybe it is, like a criteria that helps that helps them decide how to do that. And I don't know if that's something you've seen with your with your focus on geography and how population dynamics go according to that.
Yeah, with helping people kind of decide to stay in the community. I mean, I don't really track, the migration patterns in our rural community and demographics. I don't think any of them are losing population. I'd like to say that they're stable or gaining population because of the hospitals and the care that they can receive in their community, but I don't have good data for you on that.
No worries. Yeah, just out of curiosity.
Yeah.
So it's fascinating, too, that I think with with being able to increase or even hold steady services and so on, uh, along with all the challenges for payments that rural hospitals have, especially now with talk of decreasing Medicaid um, reimbursements and or just Medicaid spending. Um, is that something that you're kind of watching carefully to see how it plays out, and what kind of impact that have on your hospitals?
Yeah, it's probably the number one thing we're tracking right now is Medicaid cuts. Rural is going to get hurt more than urban when you cut Medicaid. There's just a higher percentage of patients on Medicaid and Medicare in rural communities. That's just a fact. So in Utah, we've been looking at what the Medicaid payer mix is for every rural hospital, and I would say in general it's around 13 to 15% of their total revenue. It's Medicaid. In a small frontier community, it's as high as 35%. To try to keep the doors open when you lose that much revenue from Medicaid is not going to be easy. So it really is a big concern of ours, something we're tracking closely, and trying to figure out proactively what do we do if those cuts happen. And it's not so there's multiple ways that it's going to impact a hospital, especially a rural hospital. Obviously the first way is just, patients coming into the hospital who are Medicaid patients. You're going to lose that revenue. But second, a lot of rural hospitals operate emergency medicine in the county. So some of our hospitals actually operate EMS. So cuts to Medicaid is also going to cut into their revenue from the EMS services. And then kind of the third piece is a lot of rural hospitals also own or are affiliated with the long-term care centers who are, often across the street or, on the campus of the rural hospital. So as Medicare and Medicaid cuts happen, it's gonna also decrease revenue from long-term care and those patients being able to come over to the hospital. So it's deep, right? It's multiple areas, multiple revenue streams. It really has the possibility of making a huge impact in rural health.
Are there ways that you would recommend for people to perhaps advocate for, on behalf of rural health or on behalf of just hospitals or patients what would be the best way to help advocate for for the benefit of rural health?
Yeah, well, I think the American Hospital Association, the National Rural Health Association, they're doing a great job at, really advocating and letting our senators know how detrimental Medicaid cuts will be to rural health. So if you're part of those organizations, you can join, their policy groups and share your voice that way. But really, I think the best way for the rest of us is to reach out to our state senators. The bill is with the Senate now. The House already approved it. You've got to reach out to your senators and tell them, why cuts to Medicaid are going to hurt rural health, and just let them know, let them hear your voice. And it's going to look different in every state, whether or not you're a Medicaid expansion state. In Utah, we are an expansion state, but we do have a trigger law so that if certain things are put in place, like work requirements, it could cause a trigger and the state would roll back and not be an expansion state any longer. And I can't remember the exact numbers, but I think it's around 50 to 80,000 people who would lose coverage if we lost our expansion. So yeah, it's a big deal. I think reaching out to your senators right now and do it quickly is the key.
So in addition to the federal Medicaid cuts, there would be an additional there would be basically additional cuts on the state side that would be triggered by the national law.
Yeah. Yeah, that's right. And I'm not like the Medicaid expert, but as an expansion state, the federal government covers 90% of the cost. The state covers 10%. If our trigger law happens and we roll back, it may be a 70-30, but I've also seen proposals, that go all the way to 50-50. We don't know what will happen at this point, but it definitely, in Utah, whatever happens, if there are substantial cuts, there's probably going to be a special legislative session for the state to try to figure out, okay, now what do we do with our Medicaid program, and how many people are we going to be able to continue to cover with Medicaid?
So if that were to pass, how do you see that impacting? I mean, you mentioned, so if all of those patients either lose care or have a lot less coverage of care, um, are you predicting then, let's say if that were to happen, that people would seek out care less and would only perhaps would that cause people to wait too long to seek care?
Yeah, I definitely think it would. I think they would wait longer. I think they would avoid care. And I think, honestly, it's going to be worse in other states. Utah actually has a pretty small percentage of the population on Medicaid. It's only 11 or 12%. But, you look at states in the South where it's 20, 30%. So those impacts are going to be much greater in those states. Utah generally just has a high percentage of the population on employer-sponsored commercial insurance. So that's good thing, but for those that are on Medicaid, obviously it's not going to help them. I think there's going to be delayed care. Yeah, I think obviously, as kind of my focus also on hospitals is the loss of revenue. How are we going to make up for that and keep doors open?
Hmm. Well, and on a separate and perhaps more brighter note too, I know I know you're an astronomy buff, um, and when it comes to, let's say, attracting more, either nurses or physicians to places like Utah, for instance, what are some things that people might not know about Utah that uh, like that they would love to that might attract them to the state if they had known about it?
Good question. Yeah, good. Glad to focus on a positive aspect other than Medicaid cuts. Yeah, I mean, Utah is a great place to live. I love living here. I think, if you've been here, you may have heard of the Mighty Five. You ever heard that term?
Not yet. No, I'd love to learn more about that though.
So we have 5 incredible national parks in Utah. I tried to name them all. I mean, most popular ones are going to be Zion National Park, Arches National Park, Canyonlands. They're just incredible places to come. For this may tie into kind of another topic, but for years, one of the biggest issues we had in rural health in Utah was provider recruitment, right? Trying to get people to come to Utah, come to work in small rural frontier communities. I think our environment, our national parks, our state parks, the diversity. Northern Utah is known, it's the greatest snow on earth. That's what's on all of our license plates. A great place to come and ski, be here in the winter. Obviously, we hosted the Olympics, and it's coming back in a decade. So we're excited about that. But then Southern Utah is really famous for the Red Rocks, the hiking and camping and, nice warm weather. And I love to do that myself. I was just in Bryce Canyon about a month ago. Bryce Canyon is one of those national dark sky areas with some of the most incredible views of the night sky and the Milky Way that you can, still find anywhere in the country. Absolutely beautiful. I was just telling my kids about how, there's so many stars, it's almost hard to pick out the Big Dipper, which living in an urban area, the Big Dipper is kind of all you can see.
Right. Yeah.
Right. You get out there in the dark sky areas in southern
Yep.
Utah, and it's just incredible. So great place to come visit.
Wow. So if there are any, if I'm, um, sounds like if, especially for people who are into astronomy or into hiking or, seeing natural wonders, it might be a great place to live.
Absolutely. Yeah. Wonderful place to live. Wonderful community too in general. Utah's got a great economy, a lot of great universities. And really one of the things I think is overlooked is we have a really great collaborative environment. And it even spills over into healthcare, as I'm talking about the healthcare systems that we have supporting our independent rural hospitals. There's just this great collaborative spirit of working together to make things better.
Yeah, and having, from what I know, Intermountain Health is one of the pioneers in, like uh, cleaning up processes, or in terms of like looking at processes in healthcare, to uh, with regard to quality, with regard to efficiency, things like that. And in many ways, it seems like it kind of leads the way in that area for the rest of the country. Um, and so it seems like that kind of mentality, especially from what you're doing, seems like that kind of mentality isn't unique just to Intermountain. It sounds like that's kind of like uh, more of the norm maybe than the exception there.
Yeah. Yeah, it definitely is. Yeah, we have great support in rural health from really all the systems, the healthcare systems here in Utah. Um, the University of Utah, our academic medical center, and we benefit from it in a lot of ways. Let me just share a couple. I talked about the telehealth services, but we also collaborate with them on compliance. So every year we do a compliance webinar, try to keep our compliance folks up to date. Intermountain Health actually helps our independent rural hospital network do a leadership development conference every fall. So they help us find some of their best speakers who are real leaders in legal issues and ethics, and we bring in speakers who talk on topics like crucial conversations, leadership versus managing. So we do a big leadership development conference every year. From our 9 independent hospitals last year, we had 110 managers attend and learn how to be better leaders. And that goes a long way because, as a leader, they influence, their department. They pass on what they learn in these leadership development conferences, and it just kind of makes their whole hospital better. So yeah, leadership development, compliance. Within our network, we have 9 different peer groups. One of those peer groups is all of our chief nursing officers from the 9 independent hospitals. So when they get together, or any of the other groups, infection control, radiology, we often rely on relationships with those systems to bring specialists to come to speak to these groups, to talk about best practices in infection prevention, to talk about best practices for chief nursing officers in a small rural community, rural hospital. So there's a whole list of ways that I think rural health can benefit from and leverage those relationships with systems without having to be, an affiliate or be, bought up by them.
That's cool. I think that there's a lot there that maybe for states and health systems that aren't doing this already, for them to kind of um, see and learn from, perhaps.
Mm-hmm. Yeah, for sure. And there's others. I think the fear is always there that if they reach out and ask for some of these resources, it's going to open up the door for them to, you know, um, be bought up by the system. But I think one of the areas we've really learned over the last few years where rural hospitals struggle is in revenue cycle management and data analytics. Um, they just don't have the staff and the expertise to really cover data analytics, either in quality outcomes and improving processes in clinically, but also revenue cycle, dealing with claims denials, um, prior authorization, contractual payments with commercial insurers. So if there's other resources either from the systems or other partners that can be brought in to help rural hospitals in those areas, it goes a long way. So it's an area that they all really need right now.
So I know we're running against time. So if you were to um, like, what would be the biggest takeaways that you'd want our watchers and listeners to get from our chat here today?
Mm. Yeah, I think just to kind of summarize, I guess I would say, rural health, let's not always look at it from a negative perspective. There's great opportunities. Living in a rural community is a great thing, great quality of life. And there are ways with thinking outside the box, right, to improve access to care, to bring in specialty care, to make geography and distance from an urban area irrelevant in terms of quality of care and access to care. That's kind of my motto, what I try to remind myself of every day.
It sounds like a great motto, honestly, for anyone, right? So whether it's an urban or rural setting or where have you, it's oh, well. Matt, I appreciate you joining me today, and thank everyone, thank you to everyone for being here and participating and listening today. Um, Matt, thanks again, and pleasure talking with you and learning all of these things.
Great. Thanks, Sam. Yeah, I appreciate the opportunity to share and be on the show. It's been great.